Dr. Rob Barkett Jr. is the author of Simple Medicine, No More Google Searches, which provides practical, easy to understand answers to most people's medical questions. Dr. Barkett practices internal medicine in Mansfield, Ohio. This podcast is called Simple Medicine as well. How long have you been in practice?
30 years.
Okay. So a lot has changed since 1993. In your book, you assert that the world of medicine has changed dramatically. What's the biggest change you've noticed in your 30-year career?
30-year career, I'd say the biggest change right now is the specialists, subspecialists, and where the doctor, the computer is another one, the electronic medical record. Physicians no longer, primary care physicians no longer working in the hospital setting. And those are really, alone.
So do physicians still communicate and collaborate with other physicians, or has that changed?
Oh, it's changed dramatically.
How so?
And I wish medical schools can do a better job of this, and residencies. And I don't want to say I'm a dinosaur, but I'm probably a dinosaur, but I
think you have to get past 50 years to be a dinosaur.
Yeah, okay.
Right.
Our generation of doctors did not, we had beepers. You know, we didn't have cell phones, we didn't have computers, we didn't have faxes, and primary care physicians would make their own rounds in the hospital. So every day I would go in, there's the doctor's lounge, and I would see the cardiologist in there, the pulmonologist, the surgeon, and we're all having coffee. And then if you needed a consult, you either talk to them then, or you're up on the floor, call them and say, hey, I need you to see Mrs. Jones.
Right. And
this is what's going on. They have acute abdominal pain, I think it's appendicitis, and I think you got to come see her. Where now, and I knew the primary care physician, I knew every subspecialist. And back in the day, you generated friendships.
Okay.
And, all subspecialists, I had my favorite subspecialist, but I knew everybody, and we would communicate by phone.
So if you had to make a referral at that time, you felt comfortable making the referral because you knew them both professionally and personally?
Absolutely.
Okay. And that makes a big difference.
And, when you really have that investment in your patient, you want the best for them. And so I would, think some people, and when you make these referrals as a primary care physician, sometimes I really don't care about the surgeon's personality. I know them now, and then not to pick on anybody, but sometimes the nicest surgeons are not the best surgeons, or in any subspecialty.
Sure.
And I just really like to make sure that the person I was referring to, and whatever it is, their outcomes are great. They have little complications. They take good care of their patients. And maybe you're not going to go have coffee with them, but they're the best for you.
And at least you know that if you're making that referral, chances are it's going to work out.
It's going to work out. And if there's a problem, I know they will contact me.
So when we think about changes, one of the things that's changed dramatically in my lifetime has been medical billing. You used to get a very simple invoice that said, total, insurance paid, this is what you owe. Now I can't even tell what I'm reading. It's very complicated. How has medical billing changed so dramatically?
Well, when Medicare and Medicaid came out, that was a big time game changer. And the other game changer was where we would submit, our offices would just submit by paper, to the insurance company. Now it's all electronically generated. It's all through these computers, and there's clearinghouses. And honestly, when I get a bill from mine, I don't understand it either.
So when you say it's all electronic in their clearinghouses, are there other physicians who work for these insurance companies who are reviewing your work, kind of like an insurance adjuster would look at a claim on a home? Is that what's going on?
No, it's, to the best of my knowledge, a doctor is, if I am trying to order a test, an MRI, an ultrasound, and they're trying to, the insurances are not allowing it. They do have a doctor reviewing what I've done, and if this procedure now, after they've refused it a couple times, then I can talk to a doctor. But for billing purposes, I don't think doctors are part of that.
Okay. So your day now, are you billing by the patient? Are you billing on the quarter hour? How do you do that now?
Okay.
Another
pet peeve of mine.
Yep. Because you know what the next question is going to be.
I'd say luckily I am in private practice, and this computer system that I have, I actually am kind of the biller, but I'm not the biller. I write down diagnoses. Why were you seen that day?
Okay.
Were you seen for your diabetes, high blood pressure, a sinus infection, a urinary tract infection? And I just put down the diagnosis. And then, being the secretary that insurances make us do, I got a punch a lot of nonsense buttons. You know, you're here for urinary tract. Are they a smoker? Are they not a smoker? You know, this or that. Per every patient, we have to document. And the worst thing is, which I never do, they want me to document how many minutes I saw the patient. Now, I hope you don't get me in trouble, but I think that's awful.
So, if you're seeing that many patients in a day, how is it possible to have that? And I'm going to use the word intimate, but I don't mean it in that way. How is it possible to really know your patient? Because there's a lot of volume.
It takes time.
Okay.
The first visit is always an hour visit. And, you know, we go through their family history and, you know, where they work and what their kids do or this or that. So it's really a pretty intimate the first time, and I get a pretty good base of them, but it's not until all the follow-up visits. But I don't care if they're in for a sinus, again, infection, urinary tract. I try to make some small talk. I think set the patient at ease. I'm interested in them, and you know, sometimes I make notes and I can, you know, remember what they're doing in life, where they've traveled, what their kids, grandparents are doing. And it's something that you foster over time. But really, I get to know my patients pretty well. And I think in a primary care practice, that is huge. So maybe a year for some people, 2 years, but after a while, I know the people, the patients, maybe a little bit hypochondriacs.
Yeah.
And they just most of the time need a reassurance to the person that comes in once a year for their wellness, and they're coming in. And I look at them. As soon as you've come in the door, I've already made about 18 judgments. The way they walk, the way the expression on their face, their body language, their posture, to get a really good idea of, this is bad.
So do you review the notes immediately prior to going into the examination room just to catch yourself up to speed?
Absolutely.
Okay.
So if this is any type of follow-up visit, I want to make sure that I've reviewed if they've had a mammogram, a pap test, an ultrasound, when their last blood work was. I want them to think that I'm prepared, and I won't go in the room if I'm not prepared.
So examinations have also changed. And I remember from the time I was a child, the paper was pulled out, you sat down on the paper, you were in your underwear, a little thing with the knee to test your reflexes, and we listen to this and we look at that, turn to the right and cough, that kind of thing.
Right.
Is it still the same way, or is it a little more formulaic now?
The only way I've learned about this is through patients who have been to other physicians, and they're changing physicians, because I've done it the same way every time. And it's unbelievable how some patients and some physicians now are not even laying a hand on their patients. They're not using the clinical skills they learned. They're not checking their carotid and feeling for lymph nodes, even listening to their heart a lot of times, and belly. And
how could they possibly know what's going on if they don't do those things?
Yeah, it's not just once. It's.
I mean, we don't have, what was the guy's name from Star Trek? Who, he was the doctor, and he had the little bones, and he had the little thing, and he was able to diagnose with a device. We're not there yet, are we?
We are not there, and the physical exam is still key, and it should be part of every exam. And if your doctor is not examining you, not putting a stethoscope on every time in your office, I think it's time for you to find a new physician.
Okay. Is it always the right choice to be 100% honest with your patients? Or do you have to sometimes couch or coddle what you say?
Very good question. I love honesty. And every doctor is going to, we deal with a lot of life and death and life-changing visits on every day that we work. I think that doctor and their personality is going to decide how they interact with their patients. Me, to a fault, I'm 100% honest. And
so if somebody has a life-threatening illness, like say, for example, they come in with stage 4 lymphoma cancer, and you know that the likelihood of their survival is less than whatever percent it is, are you going to tell them those odds? Or are you going to just tell them they have, a lymphomic issue?
I'd like to back up. I had this patient today,
Okay.
and now there's lung cancer screening. And
All right.
if you're a smoker and you smoked, for a pack a day for 30 years, or a 30-year pack year smoker, insurance is actually getting CT scans. And this guy's 56, and he went and got his CT scan. It was abnormal. We did a follow-up CT PET scan, and he's got a place in his lung that's just not looking right.
Okay.
So the way between this and these types of situations where there's suspected cancers, I give them the worst case scenario. I tell them what I believe, what my gut says.
Mm-hmm.
And if my gut says, hey, it's not a big thing, let's just do this, I tell them that. In this case scenario and all these other cases, I tell them first, we always need tissue.
Yep.
Until you get tissue to make, the diagnosis, it could still be anything. It still could be benign. It could be malignant in this case. But I tell them the worst case scenario, and I tell them what I think it's going to be, and then the options of seeing the surgeon or an interventional radiologist to get a result, even possibly if this is bad, seeing the hematologist, oncologist. But I tell them right off the bat, I don't want them to be shocked. Same if you're having chest pain and you come in here. I'm going to tell you, I really think this is angina. I think you have some blockage in your heart. Let's get over to the emergency or the cardiologist. And I'm telling that. 95% of them say, hey, it's not your heart. You're probably going to be fine,
Right.
But I go with my gut instinct and I go with my honesty and I usually take the worst case scenario and work back. Because if I'm wrong, perfect.
Great. So well, everybody likes good news. Nobody
Right.
likes bad news. But what happens if beyond any reasonable doubt, it's the worst case scenario? How do you convey that to a patient?
Oh, I struggled with it early in my outpatient medicine because it's in the hospital setting and residency, you're always just dealing in the intensive care unit, coronary care unit. These people are dying and you haven't developed a relationship with them. And then now that I'm here, I know the family, I know the grandparents, I know the kids. I still try not to candy coat it. I go in and try to say, hey, it may not be the best news,
Right.
because you gotta, or today I said, even today, you learn your own techniques.
Sure.
But I said, there's bad news, but there's good news today. The bad news is I really think it's cancer, but
Yeah.
this test didn't show that it spread anywhere. And if it is cancer, we caught it early, it's going to save your life. So each doctor, it's difficult. They're going to have to form their own, the way they react, they're interacting with their patients, how they're going to deliver the bad news.
How do you respond when somebody refuses treatment?
Well, other than getting really angry.
I mean, that's an option.
It is
But,
the patient's right.
Right, because let's say that somebody's at the end of the road, they have less than 3% chance of survival, and maybe they'll live another 90 days. What if they say, you know what, I just want to go into hospice?
Well, I've already made my judgment.
Okay.
So that would probably be the situation. And we had that earlier this year.
Okay.
And it's like, and unfortunately, this gentleman was 94. He lived a perfect life and if it is one of those, he came in twice, we're like, oh my gosh, something is wrong, and ends up, he's got metastatic cancer, and like you said, has 3 months to live, and we've had such a good relationship, and I'm glad, like this time, the family, that's, the patient and the doctor is usually really pretty tight.
Yeah.
They may agree to disagree at times, but you know each other. But the family comes in, and there's always one family member you didn't even know they had.
Oh, sure, and that's the one who blames you.
Yes. Oh, the doctor's
every
at
time.
fault.
Every time.
And I was glad in this scenario, like a son was in, and this guy just opted. He goes, "What is chemotherapy can lengthen my life?" I'm like, "No." And he goes, "Well, I think I just want to live my life." I said, "You know what? That's, I don't have to give my opinion, but I'm sure if I say, I think that's a good decision."
Sure.
But there's going to be the family out there that, Dr. Rob killed Dad, and he didn't do enough for him, and or they come in the office and there's just such estrangement in all families, as we know, because if you don't have estrangement in your family, you're lying.
Correct.
And I've learned to take some bad feelings from, but I know what allows me to sleep at night is I would think a pretty good relationship with my patient, and I was doing what was best with them. And there's times, it's the patient's choice. I agree with the patient's choice. Now, sometimes, I do review all options, and it is their choice, and I can't fault them. I guess as a doctor, we always want to think we can, save their life, but I just have to say the patient is in charge. But what I was going to say is, a lot of times I don't give a crap about the rest of the family.
Well, while that's not your Hippocratic oath to deal with them, unfortunately that comes with the territory that you always get the neighbors.
Because I know what that patient's wishes is. We've talked about it.
Sure. And if they have a directive, you can pull out their directive and say, this says DNR. That means do not resuscitate. We're done here, folks.
Yeah, and I always honor that.
Yeah.
And
so one of the other changes that's occurred in our lifetime, because you and I are roughly the same age, all these urgent cares have popped up all over everywhere. How has that impacted the role of the family physician, the internal medicine guy?
Well, another pet peeve of mine.
Boy, we're going to leave with a smile on our face, aren't we?
I do think a lot of patients use these pop-up urgent cares and as their primary care physician. So in that scenario,
meaning that they're not going to do anything until something's wrong,
and they don't have someone they go to. They just, is it because of insurance, or is it for?
So it's not preventive medicine; it's reactive medicine.
Correct.
Okay.
So they're getting overwhelmed. Emergencies, a lot of emergency rooms get overwhelmed with, ear infections and urinary tracts. These patients just don't have a primary care physician. Urgent care, why I think we're getting watered down in the medical care we're receiving there. And a lot of these urgent cares are manned by nurse practitioners and physicians assistants. I'm sure there's a doctor there sometimes, but they're not trained like the MDs and the DOs. The education. It's like, medical schools will have 10,000 people apply and 200 get in. So they're getting, they're sifting through. And then you have the 4 years of medical school. Then you have 3 years of residency and then whatever in the subspecialty. It's almost like Ohio State playing Ashland College here. Ohio State, you've kind of got better pedigree.
Right.
You're a 4-star, 5-star athlete. They put you through the mill, and people that aren't good enough, not to say anything about Ashland Hooters, they're a very good football school, but they're Division II. They're not Division I.
Right.
And I feel...
So these are the minor leagues.
Yeah, they're minor leagues. And of course, they do a good job, I think, on, a lot of the 70% of the stuff, but, there's 30% of the time I'm just aghast of the treatment patients received. And then they come here. I mean, I've seen ear infections. They're treated with antibiotics, and there was wax in their ear. And, if you have pneumonia to an ingrown nail, Z-Pack. So if you've ever been on Z-Pack, you've been to an urgent care. Because it's a no-thought process.
Yes.
And again, I think in this day and age, you want to go to a doctor for any type of medical emergency.
Now, when you started your practice, we had dial-up modem, we had America Online, remember those? And the internet was just at the genesis stage. The internet is far more advanced now, and we can get access to information like that. When is it appropriate to use the internet for any kind of medical questions? Because you yourself said in your book, no more Google searches. Now, I'm the rare person who just happens to have a copy of Merrick's Manual, but not everybody does.
Right.
And I know better than to go on to WebMD, because if I do, I'm dying every time. Is there ever a time when the internet can be a help to us?
I think absolutely when you have a chronic disease, any type, like we've already said, high blood pressure, atrial fibrillation, chronic disease, and you want to know more about it. But I think to make a diagnosis of chest pain or abdominal pain or back pain, that's why I wrote this Simple Medicine, No More Google Searches. And we'll get into some of those other topics, but I really don't think to try to make your own diagnosis, it should ever be used. It will cause more stress, more anxiety, and more problems than what you really have. And I literally had a patient came in the other day, she had 2 days of a flu, and she said, I want a Z-Pack. I'm like, well, what are your symptoms? And so a lot of these people, they've come in and I have a kidney stone, and they make the diagnosis. I'm like, well,
how do you know?
Back up. Let's just say, what symptoms are you having rather than that? But yeah, the internet's good for follow-up, but never to make a diagnosis.
Yeah, I remember a physician I had many years ago, when I would come in a little bit more prepped than I probably should have been, he would say, now remind me again, what medical school did you go to? And then that shut me up for the rest of time.
That's right.
During COVID, we heard all kinds of news stories about nursing burnout, nursing shortage. Did the same thing happen with physicians? Has there become a burnout factor?
Oh, I believe both physicians and nurses, I think, went through incredible amounts of stress at that time. Mm-hmm. The sickness, the death, going to work all gowned up in masks and gloves, and the acuity of it, and it changed the way medical, outpatient medicine worked too. There was a big time people didn't want to go see the doctor. They didn't want to go out of their house, and they were sick, and if you went to the hospital, you probably got COVID. And then, telehealth, which I'm absolutely against telehealth. Maybe if you're a psychiatrist or something, but other than that, you can't make diagnoses over telehealth or get a good blood pressure or that. But I really think that burnout really exacerbated the usual burnout nurses and physicians have. Unless you're a nurse or a doctor, you really don't understand the stress that's involved on a daily basis, and everyone gets burnout. Mm-hmm. And I think there's what percent of 400 maybe doctors or nurses commit suicide?
Right.
Every year.
Any percent is too high.
And I get it. I mean, every doctor is going to get it. And that's why I even talked a little bit in the book about that, how to take your time off, take your vacation time, how to spend a night or a day with your spouse, away from work, or away from the children, how to find a hobby. Mm-hmm. If you boat, if you fish, if you golf, you tennis, you pickleball,
something
you do
that
cards.
Has nothing to do with your job.
Absolutely,
that's a good recipe for coping with daily work and avoiding burnout in any job.
Exactly,
right.
And unfortunately, people fall prey to some bad habits, if it's drugs or alcohol or gambling, or and it's easy to fall into that, and you just have to know yourself, and hopefully if you have friends or other physicians see it, and can
That's right.
lend a helping hand, because it's going to happen.
The book is called Simple Medicine. It's available at Barnes & Noble and Amazon. It is also available at simplemedicinebook.com, where you'll also be able to find our podcasts. Podcast is called Simple Medicine. This is Dr. Rob Barkett Jr., and we thank you so much for listening. We'll be back next week with another episode. Take care.